Hi, everyone. I know everyone's trickling in. Thank you for joining. Give everyone a minute or two to log in. Thank you so much. Wonderful. We're getting a big bulk of everyone logging in right now. Okay. So thank you all for joining us today on this Saturday, wonderful morning. For some of you on the West Coast, I know it's fairly early. I'm Dr. Neda Joya, president of OWNS, if you didn't already know. Today, we are privileged to welcome not only a distinguished speaker, but a colleague and a friend, actually also a mentor. We're going to go into the critical topic of pharmaceutical medication as it relates to nutraceutical safety. And it's actually kind of unique. A few days ago, I received an email from a patient, and the email was about the plummeting B12 status of his body, and he ended up getting a neuropathy. And this was connected to his chronic use of PPIs, which is an over-the-counter medication for acid reflux he was using for so long that his B12's tanked. Now, that might not really pertain to maybe what you're doing clinically, but this was a unique situation because this patient also had a history of optic neuritis. So this lecture is so needed, and I'm going to say we need more lectures like this because more and more patients are taking medications, whether it's over the counter or prescription. So I'm going to move on to a couple OWNS-centric items. We have our social media up and running, our Instagram. Please follow us at the OWNS Society. And our Facebook has been open for a long time. And now our LinkedIn has been increasing in activity. So find us on all the socials. Just to emphasize, we really want you to use the Q&A box for any questions versus the chat box. And we do have our EA, Erica, helping to navigate that today. Another quick reminder, if you didn't already know, your membership perks have been increasing, and we continually try to increase them throughout the year. The one big one that we just launched is Find a Practitioner. That actually allows you to connect to patients and obviously other colleagues. So this has been really critical because we get questions from general patients who are looking for a doctor in their area who really want to understand their nutritional status, for example, or even somebody who's just open-minded to holistic care. So if you haven't registered for that, that is in your membership perks, and you just log in. You'll find the button in your membership benefits section. And then a very long relationship we've had with ABO, but it has expanded this year. You can tap into now the ABO COPE-approved webinars. We have one launching next week, and that is also a sign up that's within your membership profile. So that will continuously grow this year. A quick recap, if you didn't already know, we really had a wonderful launch with the ANA this year for the highest nutrition discount tier for their personalized nutrition practitioner training program. This has really catapulted some of the education for our general doctors out there, and it's necessary because you're not getting it in optometry school nor medical school. So it has solidified that confidence in whole body nutrition, and it's still active. It will not be forever. So if you haven't tapped into it, please tap into it soon. So now my formal introduction to Lara, Dr. Lara Zakaria. She is a pharmacist, a nutritionist. She's focused on implementing solutions for functional medicine and personalized nutrition. She's a graduate of the School of Pharmacy at Rutgers, and she's spent 20 years in community pharmacy practice. She's developed quite a big interest in nutrition. She earned her MS in nutrition. Her list is very long. Her MS in nutrition from the University of Bridgeport. She's a certified nutrition specialist. She was one of my biggest mentors in that. She's also an IFMCP, a Institute for Functional Medicine certified practitioner. She focuses on multidisciplinary approaches to, and both one-on-one to patients, as well as creating implementation tools and systems for scaling. She's an adjunct professor for nutrition, nutritional biochemistry at the University of Bridgeport, faculty at GWU. The list goes on and on. She's also one of the newest board members here at OWNS. So I am so honored to present her webinar today. As she's hosted many others, I hope I host her just as well as she hosts everyone else. All right, so without further ado, I'm going to allow Lara to start screen sharing her side.
Thank you so much, Dr. Netta. And it is such a pleasure to be here with all of you today. What a warm welcome. I have really grown to appreciate and love this audience for how much I've learned about the impact of ocular health. So if I could give just a little bit back, it is absolutely my pleasure and my honor to be here today. So I'm going to go through these. I like to use the chat box. So if I might periodically ask some questions, make sure you guys are still awake and alive out there. So if I poke a question at you, you could put that in the chat box. But please, as Dr. Joya said, please put any questions that you have into the Q&A box so that we can save them for the end. I'm going to do my best to stay on time today. This is a topic that's really near and dear to my heart. So hopefully I can do that, but hopefully we'll have a few minutes at the end. So any questions that you have, please put them at the Q&A, and I look forward to hearing them and getting to know you throughout this conversation today. So here are my disclosures for you to review. Today's objectives, we want to identify some of the opportunities that we have regardless of our background. We are going to encounter patients that are going to be on medications. And so whether or not that is our area of specialty, inevitably, if we are going to make recommendations for either nutraceuticals or we're in the realm of nutrition, we want to make sure that we are doing it in the safest way possible within our scope of practice. We want to talk about strategies where we can make sure that we are mitigating any potential side effects. That example of the PPI, DIN, drug-induced nutrient depletion of B12 is a great example of such a low-hanging fruit, such an opportunity. You don't have to do anything about managing that PPI, but a supplement of B12 can go a very long way in mitigating some of the side effects that he was experiencing from that medication. And then third, we're going to examine the various nutraceuticals, nutrition, and lifestyle principles that can really help our patients achieve their health goals. Ultimately, if you're here at OWNS, then I think that we agree that the principle of whole health and really looking at the person holistically is something that we hold near and dear to all of our hearts. And so towards that, we want to make sure that we are doing this in the most evidence way possible. So this is a term that I have completely made up. Pharmaconutrition. And I really hope that today you can help me make it a thing, a real word that we use somewhere. And what I mean by pharmaconutrition is the idea that we don't necessarily have to choose between nutrition and pharmaceuticals. There are a lot of cases where pharmaceuticals are essential, they're needed, they could be even life-saving, right? And so I want to be very clear here that in those situations, what we want to do instead is leverage nutrition and whole health and lifestyle medicine as a way to bolster and again to reduce the risk of side effects that come with the use of pharmaceuticals. Of course, there's a whole other conversation about the overuse of pharmaceuticals and whether it's appropriate or not in all situations. That's another conversation for another day. But today, let's focus in on the things that we can do that are within our scope of practice, that are applicable, and that could really help turn the dial up on somebody's whole health. The reason that we have to have this conversation is that in the United States, it is estimated that 860 million drugs are prescribed. This is a 2018 statistic, by the way. This is the most recent statistic that I was able to find. It's likely also gone up since then. Post-COVID era changed a lot of things, and prescription use in the past 30 days. This is essentially when you survey individuals, how many prescriptions were they taking over the last 30 days? 48%, at least almost 50% of people are at least one prescription. 24% are on 3 or more prescriptions, and 12.8%, almost 13%, are using 5 or more prescriptions. So it is inevitable for us. 1 in 2 patients that you are seeing in your practice right now are on at least one medication. And so I'm sure you're already screening for those medications. And again, if you want to have that conversation more holistically about nutrition, maybe even you're recommending nutraceuticals or supplements, this is an important conversation to have today. So let's go back a little bit in time. Let's review a little bit of pharmacology. For some of us, it's been a long time since we sat in a pharmacology class. So this is just meant to be a quick little refresher. So the fundamentals, when we talk about whether it be drug interactions or drug-induced nutrient depletions, one thing that we're generalizing is that there's a class similarity. So whether when we're talking about specific drugs, very often we don't have a lot of data about individual drugs. So we often will extrapolate what we know about one drug to other drugs that are within that same class. Now, is this perfect? No. Is it ideal? No. But we generally can say that if a mechanism of action is being followed by a medication, then more than likely the side effects, the drug-induced nutrient depletions, and the interactions likely are associated. So you'll see very often, even in the literature, well, they'll clump together a class of medications. So rather than saying sertraline, they might say SSRIs interact with XYZ. A term that I really love introducing is pharmacognosy. Pharmacognosy is the specific branch of pharmacology where we study natural substances to learn their mechanisms of action in the pursuit of developing new medications. A great example is red yeast rice and lovastatin. They're essentially, in principle, the same. We essentially learned what red yeast rice does, isolated the active compounds, then created a synthetic version, and that's how we actually produce lovastatin. From lovastatin, then we have all the other statins and anti-cholesterol medications within that class on the market. There's other examples, of course. One that comes to mind is aspirin that comes from willow's bark, but there's a ton of these examples. And I find this really interesting and really grounding as a reminder that the principles of how plants work and the science behind plant medicine is actually really well studied. However, it is studied mostly in animal models in order to derive information to create a synthetic substitute that can then be manufactured into a medication. We do have some RCT trials in humans. We do still have some meta-analysis and reviews on nutraceutical compounds and plant compounds. They're not as robust as we would like them to be, but they are out there. So it's important that when you are sifting through the literature and trying to understand a mechanism or trying to understand the safety profile of a particular nutraceutical, that we understand that it's going to be, we have to be careful where we're citing that literature from. And then the last principle here to keep in mind is that all drugs have side effects. It literally doesn't matter what it is, over-the-counter, prescription, controlled substance, non-controlled substance, all of them are going to have side effects. You'll hear me also refer to them as adverse drug reactions or ADRs. And these are not always meant to be part of the mechanism, although sometimes we might use those side effects to our benefit. Most of the time, I'm making up a statistic here, 90% of the time or more, those side effects are unwanted and things that we want to mitigate. And very often that side effect increases as the strength or the dose of the medication goes up. So very often we're trying to use the lowest viable therapeutic dose in order to achieve a therapeutic effect so that we can also mitigate any potential side effect or toxicity that happens from higher doses of that medication. But it cannot be completely avoided. That said, many of those side effects, not all, can be contributed to the drug-induced nutrient depletions or DINDs that are associated with that drug. We'll go back to that same example from the PPIs. Thank you for giving that to me earlier, Dr. Netta. Makes it easy. Those PPIs are going to reduce the absorption of certain nutrients, particularly B12 in this example, and that contributed to that side effect of the neuralgia, which from your perspective as an ocular specialist is that it's going to then obviously impact their vision. And I forgot what the specific condition that patient had, forgive me, but you can see how you can start to pull that thread and make the connection between that drug-induced nutrient depletion from what, frankly, some PPIs have become over-the-counter at this point. So that might seem benign. They're taking it without even thinking. They just think they're just popping an OTC medication, but in fact has this longer, more substantial side effect as an impact. So two things that we want to monitor, and this is what your pharmacists and hopefully you have a good relationship with the pharmacists in your community are trying to consider. One, yes, they're holding space for those adverse drug reactions. Very often part of what we're trying to do when we have our consultations with our patients is to make them aware of the potential side effects and the adverse reactions that they could experience from that medication, and to help them navigate the adverse reactions that might be more benign and might even subside after a little bit of time on the medication versus the ones that should raise a red flag and would from there initiate the cascade of either changing the medication, adjusting the dose, etc. On the other side of that, we're always thinking about compliance, and compliance refers to ensuring that somebody remains on the correct dosage for the correct duration of their medication. So a great example of this would be antibiotic safety. So we want to make sure that folks are taking their antibiotics, that they are taking them for the correct number of days, and that they're not missing any doses, because as we know, if they don't do that correctly, although they might feel better, we increase the risk of antibiotic resistance and potentially have them remain sick and or get sick again as a result. So it opens up a whole can of worms that we want to avoid. So that's one simple example. One of the things that contributes to people not being consistent on their medication is compliance factors that are related to adverse drug reactions. So we've come full circle. Very often when people experience adverse reactions, either they are not tapping into their resources, whether it be their prescriber, their healthcare team, their pharmacist, and they're basically saying, oh, I don't like the way this drug makes me feel. I don't trust this drug, and they stop taking it. And so a big part of the job of having that pharmacist there is to make sure that they understand that they have options. Very often they don't know that they have the ability to ask for a different medication, or there might be different options there for them. Sometimes they also conflate adverse reactions with actually symptoms of their actual original illness. And so they're conflating the two because it may have gotten worse around the same time, or because they're inconsistent with their medication, the symptom got worse. So that education piece becomes really important. And at the same time, as a functional pharmacist, my thoughts are, well, if you're experiencing adverse reactions and that's impacting your compliance, and this is an important medication for you to remain on, then what are some of the things that I could do from my toolkit that I could bring to the table that can reduce some of those adverse reactions, improve your compliance, and overall improve your health outcomes? And I'm curious, I'll take a break here before we move into the meatier topic here of drug-nutrient interactions. I'm curious how many of you have a relationship with a pharmacist, whether it's a pharmacy that you trust that you call up with medication questions, or a pharmacist that you know that you send your patients to because you're like-minded or has a good supply of either pharmaceuticals that you use often or nutraceuticals that you like to recommend. I'm just curious if you've already fostered that relationship with your pharmacist in your community. So you could type that into the chat box for me and we'll take a look at that. So I'll dive in and we'll come back to the chat. All right, so DNI's drug-nutrient interactions. This essentially is speaking to the relationship between drug and nutrients in general. And what's important to keep in mind is that this is a bi-directional relationship. So we often think of how nutrients might be impacted by drugs, but drugs can also be impacted by the nutrients. So this is a complicated graphic, but it's got a lot of great information in there. So I encourage you to sort of pause this when you get a chance and really zoom in and take a look at all the various factors. If you look at that top circle, the risk influencing factors, you've got patient-related factors, drug-related factors, and nutrient-related factors. All of these are then in turn going to have an impact on the drug-nutrient interaction. So it's not simple enough to say that if you take this drug and you have this nutrient, then there's going to be an interaction of some sort. That doesn't always have a one-to-one outcome. There are so many, dozens of factors, in fact, that are going to impact the extent of that relationship. So that's one piece that I really want to make sure that we keep in mind. The other thing that I want you to also consider is that we're just starting to learn about the nutritional impact and various nutrients, whether they be phytonutrients, antioxidants, certain nutritional compounds, how they potentially impact our epigenetic expression and how they impact our microbiome. And so if we sort of zoom out and think about how the microbiome is then going to impact a lot of other physiological function, including our metabolism, our ability to detoxify and to metabolize pharmaceuticals. We've actually also learning how certain pharmaceuticals are impacted by the microbiome as well. So there might be a reason why in some people a medication works really well and in others it doesn't. It might come down to their microbiome and the specific balance of the microbes that they have. Another piece of this is that epigenetic piece, the translation of the genetic code that happens when we interact with certain nutrients. All of these factors can potentially impact how that drug acts on our body. So long-winded way to say that this is more of an art at this point than a science. We're trying to understand all these, but we don't have a lot of literature to really help us say, well, if this, then that. It does take a little bit of taking into consideration the patient population, all these other influencing factors that are up top, as well as putting that together with the potential drug-induced pathways that will then impact the outcome of the medication. Okay, I'll open up the chat. Working in a hospital allows me to communicate with my pharmacist anytime I have questions. Super helpful. I'm so happy to hear that, Randall. Fantastic. Awesome. I love hearing it. Keep using the chat to tell me what your relationship with your local pharmacist is like, and hopefully it's a good one. Examples of drug-nutrient interaction. I'm going to use a medication called metoclopramide. Metoclopramide is used for motility. So metoclopramide's job is usually to help increase GI motility. So we use it very often for like constipation. Sometimes it's used in opioid-induced constipation, for example. And so that medication does its job and increases transit time and allows then the stool to move through the intestines at a higher rate. Now, somebody that might be taking this as a chronic medication, they might then experience bouts of very loose stool, or as a result of that increased motility, it starts to alter the absorption time of certain nutrients. It's also going to alter the microbiome at the same time. Anytime you alter motility, that's going to alter the balance of that microbiome. As a result, you might experience specific nutrient loss, particularly the nutrients that require a specific transit time in order to be fully absorbed. This might then in turn increase the metabolic risks are associated with those nutrients. And then as a result, you start to see sort of this compound effect where you get worsening digestion because of the dysbiosis, because of the nutrient depletion, and an increased need for that medication. So this is sort of an example of this downward spiral that can happen as a result of a drug-nutrient interaction. So some of the mechanisms associated with drug-nutrient interaction, one would be alterations in the digestive environment that then alter the ability to absorb that drug. So an example with that, certain fatty foods, for example, will decrease the bioavailability of certain medications. At the same time, you might see certain medications recommend that you eat a fatty food with it to improve absorption. Another example would be changing the gut microflora. A classic example would be the use of antibiotics. Obviously, when you're taking an antibiotic, it's non-specific. It's going to impact also the bacteria that's in the gut environment and on the skin and in the lungs and in the vagina. And so all of those things are going to shift and alter. And specifically in the gut, because that also contributes to the nutritional absorption, might have a cascading effect. For example, vitamin K deficiency can be associated with chronic antibiotic use because we actually produce a significant chunk of vitamin K thanks to our microbiome. The third example is forming insoluble complexes. A classic example here would be your fluoroquinolones, which is a class of antibiotics that might bind with iron or magnesium or large ions or elements, preventing the full absorption. So as a result, you wouldn't get the full benefit of the antibiotic, which would then reduce the overall dose, which then would also increase the risk of drug resistance. Fourth would be alterations in gastrointestinal pH. So there are certain medications that are only bioavailable at certain pHs. They're actually, it's kind of brilliant, made in a way that they release in a certain part of the digestive tract. So whether that be in the stomach, in the small intestine, or in the colon, it's all dependent on the pH. So anything that changes the pH of that particular location will then impact the bioavailability and the stability of that drug. The opposite can happen too. If a medication requires that it be in a certain environment to be protected, once it hits, let's say, a highly acidic stomach, for example, that's more acidic than it should be, might actually render it completely not useful. It might break down before it even reaches its active site or its active absorption site. And then the fifth one would be what I think most people have the highest association with drug interactions, drug nutrient interactions, which is the induction of the CYP450 enzymes. These are what are part of the phase 1 detoxification pathways, and we've all learned them as part of the activation and detoxification biotransformation mechanisms of medication. And very often the drug herb interactions and the drug nutrient interactions have to do with either slowing down these enzymes or speeding them up. So a good example is statins and grapefruit. I am old enough to remember when that grapefruit statin interaction was discovered. It was like all over the news. I had 5 million phone calls coming into the pharmacy at the time asking me, my God, I've been drinking my grapefruit with my statin, you know, how dangerous is that? So that's a great example, because what happens is it inhibits the 3A4 pathway. The 3A4 pathway is responsible for metabolizing statins. Most statins require that 3A4 pathway in order to be removed and metabolized, meaning if you inhibit that pathway, you're going to have a backup of the statin, which could lead to increased toxicity, adverse reactions, things like the muscle pain side effect that a lot of people experience with statins. There is at least one statin that's a prodrug, and so it actually needs the CYP system in order to activate. So in that particular case, you have the actual opposite problem where you're inhibiting its activation, and so you don't get a sufficient amount of that medication. So there's a little bit of nuance in this one, but generally speaking, when people are talking about inhibition induction, they're talking about that phase 1 detoxification CYP system. Some of the hit parade, as I like to call it, these are the 4 top drug nutrient interactions that we come across a lot. One are your tyramine containing foods. So these are your cheese, wine, sausages, salami, soy sauce. All of these act by degrading MAO, monoamine oxidase. And there's a class of medication that's used for mental health management, which is called monoamine oxidase inhibitors. And what it does is, as the name implies, inhibits this pathway. So this is a pretty significant interaction. There's also an overlapping, we need that MAO in order to balance our blood pressure. And so it can lead to a hypertensive crisis when the two are combined. Vitamin K rich foods, so these would be your leafy greens or your super green vegetables. It includes Brussels sprouts, kale, some of the cruciferous vegetables, etc. What happens here is these are particularly rich in vitamin K. There are different forms of vitamin K, and there are different anticoagulant medications. The one specific one that uses this vitamin K pathway are your Coumadins or your warfarins. The brand is Coumadin, the generic is warfarin. These use this pathway specifically. And so therefore, when you add more vitamin K from the diet, what ends up happening is that you essentially cancel out the effect. You actually exaggerate the effect of the warfarin. And what you end up happening is excessive bleeding. So in these patients, what we usually will recommend, very often they are at a Coumadin or a warfarin clinic in order to really tightly manage their INR to make sure that they're not bleeding out or that they're not coagulating. And what happens there is they get counseled on the amount of these vitamin K rich foods they should have in their diet. So it's not about eliminating the foods altogether, but rather consistently having them eat it day to day to ensure that the vitamin K levels are stable throughout their diet from day to day, and so they don't experience that adverse reaction. Dairy products. Dairy products are very rich in ions, these divalent ions. There's big, heavy molecules that like to complex with other things. So calcium, for example, magnesium, etc. These can compound with other medications. Again, we use that fluoroquinolone as an example. There's a couple of other examples for you there as well. Usually this is a simple avoid while taking that medication. So you just don't take it at the same time. You space it out by about 2 hours to account for any slow motility, and we should be fine. And then there's the infamous grapefruit. Now, grapefruit gets a bad reputation. I was just having a conversation with a friend of mine who says that she exclusively has omitted grapefruit from her diet because she's heard it interacts with so many things that it could be potentially bad. And I think this is a really interesting piece. She's only on one medication, levothyroxine. And so she was very concerned that it was impacting her levothyroxine, and there's not a notable interaction there. So I found it really interesting, and we had a conversation about it. And I think what it really taught me is that there's always an opportunity to have these conversations, because grapefruit, on the other hand, can be really helpful for helping to support estrogen dominance in women who are experiencing those symptoms, that have PMDD, who have heavy menstrual periods, et cetera, because of its impact on that phase 1 metabolism. It actually could be really therapeutic in that way, just a way to use it as food as medicine. That said, be mindful that because of that mechanism, it could also, there could be a drug interaction with oral contraceptives, hormone replacement therapy, particularly estrogens, and also there are some notable interactions with, as we mentioned, statin, calcium channel blockers, which is the class of antihypertensives, and certain psychotic medication. Awesome. All right, moving into more specifically drug nutrient depletions or drug-induced nutrient depletions, DINDs. There's a slight nuance difference in my mind between drug nutrient interaction and drug-induced nutrient depletions. Drug nutrient interactions is sort of like an umbrella term that talks about all the potential interactions that can happen. Drug-induced nutrient depletions, on the other hand, are more specific to how a medication induces a nutrient depletion very specifically, right? So in this case, what we're talking about is how a medication might block, impair the absorption, storage, metabolism, or synthesis of a nutrient. And that could be a direct effect or can be an indirect effect, which I'll clarify the difference there in a second. And this often, again, just like with what I said before with the drug-nutrient interactions, this also requires a bit more of a critical lens and a bit of a assessment of the interpretation. So very often you can go to a database and pop in the drug and see a list of nutrient depletions. But again, I encourage you to kind of put on more of a critical lens as you're reading through them. And let's use an example to sort of illustrate what the DIND is doing, and we'll talk through what we know in terms of the resources. So this is what I call the DIND cascade. So you've got a patient that presents with symptoms, maybe it's abnormal values, they go to their doctor and they get started on a medication that addresses those concerns. From there, that medication addresses the symptoms, their lab values even might normalize, fantastic, we feel like we did our job, but they remain on that medication in order to maintain those results. Then in turn, that medication starts to have an effect on that body, on their body in terms of nutrient depletions. So that nutrient slowly, gradually starts to deplete, especially if they're at risk of depletion of that particular nutrient. And over the course, it could be weeks, it could be months, it could be years. Again, it depends on the nutrient, depends on the person. They can develop another set of symptoms due to that drug-induced nutrient depletion, like that PPI and the B12. From there, that patient returns back to that physician, says, hey, I've got this new complaint. Now I've got nerve pain. And so what does the doctor do? Starts them on a new medication to address that nerve pain, but misses the opportunity to address that drug-induced nutrient depletion. From there, the whole process starts again, because maybe that medication does help with the nerve pain, but it never addressed the root cause, which was the depletion of that original nutrient that could have been easily we could have closed that gap pretty easily and probably gone on our merry way. So one concept that I think is really important to understand before we dive any deeper is that there is a spectrum of nutritional status, right? We often think of whether something is within reference range or out of reference range. So it's either in or it's out. But the reality is that there is a wide spectrum between what is deficient, outright deficiency, and what is optimal on the other side of the spectrum. And somewhere in between is insufficiency. And not only is there a spectrum, like a sliding scale, but an individual's needs based to genetics, lifestyle, personal needs, habits, etc., are going to then dictate how insufficient they are. So somebody that's out running marathons is going to have a very different nutritional need than somebody who's more or less sedentary, right? And that is going to decide whether that sliding scale is even more insufficient than what we would optimally consider very repleted or very optimal. So that's something really important to consider, because again, somebody might take a PPI for 3 months and experience that B12 deficiency, but somebody else could take it for a year and never have that B12 deficiency. They might be already taking a B complex that has a B12. They might have a diet that's very rich in B12 already. They might have a lower need for B12. So there's a lot of factors that can play into the spectrum of nutritional status. So what are some of the factors that can influence said DIND and how much it impacts an individual? Well, one, how many medications are they on? Because the more medication somebody's on, the more polypharmacy they experience, the more likely that there are interactions, the more likely there's metabolic demand, there's increased demand on metabolic and detoxification pathways, on gut, et cetera. And all of these are going to impact their nutritional status in a different way. Elderly. They're altered pharmacokinetics. So the way that a medication acts on a older individual versus a younger individual is going to shift. There's also what is their initial nutritional status? What deficiencies did they already walk in the door with? Did our person who was experiencing symptoms walk into the doctor's office with these symptoms already have an experience where they're insufficient in certain nutrients, and then you gave them that medication, and then now they're really deficient in that nutrient? And then the last one there is chronic health conditions. Anytime somebody is already experiencing a chronic condition, they already have an increased physiological demand, and they have altered metabolism. Again, their need for certain nutrients is going to be changed from the average healthy person. So those are all factors that we want to keep in mind as we consider drug-induced nutrient depletions in a particular individual. And I find it's interesting. You don't always see the symptoms of nutritional deficiency right out the gate. Very often in the early stages of insufficiency or even depletion, you'll just see first a depletion of stores. I think of iron, for example. You don't often see somebody, assuming they don't suffer from chronic anemia, when their iron levels drop, the first thing that happens is our ferritin goes down. Our storage in our liver actually depletes because the body's trying to compensate, and it starts pulling from the storage in order to cover its bills. So it's like pulling from your savings account in order to cover the rent that's due. From there, you start to see now there's insufficiencies of that nutrient. It starts to pivot that nutrient to go into different pathways because it's starting to now prioritize where it would potentially go. So for example, it might say, you know what, hair growth isn't the really most important thing that I could do with this iron right now. I need to revert this iron in order to help go support thyroid production, for example. So you might see hair loss before you see any symptoms of thyroid dysfunction. And then from there, you'll start seeing changes in enzymatic activity. So if that nutrient is needed as a cofactor for certain mechanisms, you'll start to see a downregulation of those enzymes, because if you don't have the cofactor to run that enzymatic pathway, then you're not going to be able to run it as fast. So you start to see compensation mechanisms happening and slow down. An example I would use here is folate or B12 or B6 that are involved in methylation and the MTHFR gene in individuals, whether you have an MTHFR mutation or not. If you see depletions in B12 and folate, you're going to see a downregulation of the activity of that enzyme. So in turn, that's going to impact all the downstream effects of that enzyme, including detoxification, and in some cases, even the metabolism of certain medications. Next would be impairment of outright metabolic or cellular function. This is where you start to see a significant but reversible. Step 4 is still reversible, where something changes And you're seeing the compensation mechanisms of that altered function. So this is where you might see the CBC start to alter and somebody's symptoms really significant because of that iron deficiency, for example. It's significant enough that you're starting to see alterations in the way the body is handling low iron levels. And then step 5, which is quite extreme, is where you get tissue damage. This is irreversible. It's usually, this is outright disease damage. And this is what you want to avoid. So we want to try to catch these deficiencies and depletions early on in stage 1, 2, or 3, rather than wait till we get to 4, and definitely before we get to 5. So what are some of the mechanisms? Let's drill down into them a little bit more. Number 1 would be inhibition of nutrient absorption. I'm going to use PPIs as an example. So these are going to prevent the absorption of certain nutrients, including B12, folate, and calcium. Inhibition of nutrient synthesis. So this would be statins and the classic depletion of CoQ10. This is why we often recommend CoQ10 when people are taking statins long-term. Third would be alterations in the transport of nutrients. In this case, metformin inhibits the absorption of B12 across the GI lumen. It also inhibits folate absorption. An increase in the metabolism of a nutrient so that it turns over and gets used up too quickly. A great example of this would be estrogens actually increase the metabolism of certain B vitamins. Increase or decrease in the excretion of nutrients. So you end up eliminating the nutrient faster. An example of this would be ACE inhibitors, which is a class of antihypertensives that increase the excretion of various elements, particularly zinc. And then next would be alterations in the body's ability to store a nutrient. In this case, we're talking about things like caffeine or alcohol. That would be, it would be allowing basically things to run through faster. So let's talk about the specific factors that are going to impact nutritional status. So talking from the top up, what are some of the things that we would screen for in addition to looking at specific drug-induced nutrient depletions in a database? One would be biological factors. They're strenuous. Are they doing any strenuous physical activity? Do they have a job that keeps them up and active all the time, or are they more in a sedentary job? Do they have any chronic disease conditions that might alter their metabolism or their nutritional needs? Are they healing from a surgery, a wound, a psychological or emotional trauma? Are they experiencing any metabolic disorders? Do they have any GI issues, particularly anything that's going to impact their absorption or lead to maldigestion, malabsorption from their diet to begin with? Do they experience any IBS, or do they have something like SIBO or anything like that? Have they had gastric bypass surgery? And then next would be genetic factors and biodiversity. This starts to touch in not only on their Mendelian genetics, things that they have that we can't necessarily change, as well as things that maybe are adaptable and can be shifted through epigenetics. And then external factors would be the specific medications and their impact on the DIND. So this would be something that has a sliding scale based on some of these biological factors. Any particular drug interactions with other nutrients, or nutrient interactions. Sometimes certain nutrients block the absorption of other nutrients, for example. What's their dietary quality? Are they eating a really nutrient-dense diet, or do they tend to eat more of a standard American type of junk food diet? What kind of environmental exposures are they under? Do they live near a highway, for example, and they're exposed to a lot of air pollution? Is their water quality clean? Do they have a job or do they live in a place that might have a lot of heavy metal exposure? Are they using a lot of plastics in their life? That kind of thing. And then last would be climate and geographic locations. And the best example I have for this is vitamin D exposure. If you're in the Northeast and you don't get a lot of sun exposure like me, most of the year, that's going to significantly impact your vitamin D status, and that I would consider that an environmental exposure. But it could also lead to stressful environments. If you're living in a situation that's unhealthy or unsafe, that might lead to more physiological or even psychological stressors. So again, I want to reemphasize that there is an art to drug-induced nutrient depletion assessment. Yes, there are great databases, and towards the end of the lecture, I will share some of my favorite databases with you. But At the end of the day, you can look these up and you can see what the literature says. But number one, the reality is we don't have a lot of research, particularly on newer classes of medication. And as I mentioned earlier, just on specific drugs, we're sort of making a lot of generalizations. So it's really important for us to put our clinical thinking cap on, to think about those bio-individual variables and how they're going to impact nutritional status to begin with. And keep in mind, just because somebody's on a medication, I don't always assume that they're depleted. If you're in a position to run any additional lab assessments to ensure what their status is and then really personalize the recommendations, I think that that is a really prudent first step. If not, and you kind of assess the risk versus benefit of using a supplement and or making even food recommendations, that's fine. But just keep in mind, it's not always as simple as everybody who's taking XYZ needs XYZ nutrient. Okay, let's talk about drug-herb interactions. Again, if you're making recommendations for any nutraceutical or herbals in your practice, this is particularly important. And the reality is that this is as of 2020. This is actually this was published before the pandemic really hit off, and the numbers actually went up since then. But consumers in 2020 spent $11 billion on supplement. And in 2021, the market grew as a result of the pandemic by 7.5%, and it topped at $59.9 billion. And that was $5 billion higher than the estimate that they had pre-COVID. The industry is now expected to grow by another 10 billion through next year in 2025. And this is a global phenomenon. So this is not something that we're going to escape. The interest in nutraceuticals, herbals, holistic and traditional medicine is here to stay. And frankly, I'm okay with that, but it comes with a responsibility on us as clinicians and practitioners to really educate ourselves on this topic. I'm curious, you could put this in the chat and I'll come back to it, but if you are already either recommending herbal supplements or if you're doing some due diligence in your practice at the moment, to ask your patients about their use of nutraceutical supplements, herbs, etc. I'm curious what it looks like in your practice. So the problem is that although 30% of Americans, 1 in 3 people walking into your practice are likely taking at least one herbal supplement, 25% of those people, of that 30%, are also taking a prescribed medication. So if you think about, there's at least 50% of people taking at least one medication, 30% of Americans are taking at least one herbal supplement. The overlap is at least 25%. What's interesting, though, is that 40% of patients surveyed do not disclose their herbal supplements to their healthcare providers. And I think this is a really dangerous thing, because what happens is now you are unaware that are taking a potential herbal supplement. Forget the quality of that herbal supplement. That's a whole other conversation that we can have. It's its own lecture aside. This means that you're not fully making a decision aware of the potential interactions. And the reason that this happens is because a lot of patients have either faced some, negative feedback from their practitioners, or because they don't believe their practitioners understand supplements. And I actually did a very informal survey on my social media, so take it for what it's worth at face value. How many people talk about supplements with their providers and why they didn't? And most people that responded, I would say like 60-ish% people that responded said they don't talk about herbal supplements because their doctors don't believe their doctors know anything about it, and they're just going to be dismissive and they didn't want to deal with it. So just having that basis where you are willing to have the conversation, you are branding yourself as somebody who is herb savvy and supplement savvy and open-minded, I think goes a really long way to preventing these potential negative side effects. Yes, omega-3. So you're already using, Linda, omega-3s mostly. Lots of great data on omega-3s and eye health. So that makes a lot of sense. And there's some interesting data about using omega-3s alongside certain medications in our chronic disease patients. So that makes a lot of sense. Okay. back to my favorite word, pharmacognosy. So it comes from the Greek roots of pharmakon, which is drug, and cognosis, which is knowledge. And so essentially the term is implying how we can derive more knowledge from the herbals and the traditional medicine that we are aware of to develop even more potent medications. And when it comes to pharmacovigilance, which is how in the pharmacy field, we identify opportunities for interactions, whether it be drug-drug interactions, drug-herb interactions, drug-food interactions. We're looking at the potential for drug interactions and what the drug does, potential comorbid conditions, the pharmacogenetics, the impact of genetics on the pharmacology, polypharmacy, multiple medications, what they're taking, how much they're taking of it, and then are there any particular therapeutic windows we have to pay attention to? A therapeutic window implies that a small change in the blood level of a medication has a big impact on its outcome. Wider therapeutic window is relatively safer. It means that if there is a change in that blood concentration, you still get a benefit from the medication. It's not significantly impacted. When it comes to herbs, we also have to take into consideration there are a lot of variations in plant constituents to begin with. This is where we sort of touch on the importance of herbal quality and supplement purity. There's also confusion when it comes to plant names. I literally, in one of my classes, just corrected a student who was talking about the side effects and the uses of ginseng and was confusing the different kinds of ginseng. So was going back and forth, assuming that the plants were similar when they actually have very different applications, implications, and active compounds. Mislabeling of products. We've seen this actually in the consumer market. I've seen this also where patients will order from what is supposed to be a reputable site and they end up with a mislabeled product. And then you've got also manufacturers who are doing this on purpose, unfortunately, and mislabeling constituents of their products. And the use of multiple botanicals increases the risk of potential interactions and might double down on certain pathways, particularly when it comes down to drug-herb interactions. So the reality is that the culture that we live in, every single one of us, myself included, have been raised and taught in a culture, in a medical culture that is quite dismissive and biased against herbs in general. And so very often our literature is a reflection of that and probably is why we hold this bias. So it's a two-way street here. Because we often look at the potential danger of the herbs when we're looking and conducting herbal research, especially when it comes to drug-herb interactions, we're mostly looking for the problems. And we very often over-exaggerate the potential problem. And this is Ivan Stockley, who is a fairly big name in the field of pharmacovigilance and drug-drug interactions, says that even when it comes to drug-drug interactions, we often overstate the impact of those interactions. We actually don't know how significant they can be because there are so many variables that are involved. We're often erring on the side of precaution and safety. And I would argue that that's probably not a bad thing, that we should be more cautious. I'd rather cause no harm, of course, but that also really brings to light the potential opportunities we might be missing in the use of herbals, not only to reduce some of the adverse risk when it comes to medication, but to even potentially improve the efficacy of that medication. So rather than avoiding them altogether, are there opportunities for us to really leverage and use synergy to better treat and manage our patients? Awesome. Yes, I would love to see more education on this topic. I agree, Sharon. I couldn't agree more. Awesome. All right, literature on drug-herb interactions is lacking, and very often we lack sufficient actual clinical trials. The vast majority of the literature, as I alluded to this earlier, is in vitro, which, as we know, animal studies don't always translate to clinical practice. They make great starting points for understanding mechanisms, and we could really understand how something works. And of course, the pharmacognosy, how we can use it to develop more potent either nutraceutical options or pharmaceuticals. However, we need more human data to make better clinical decisions. We do have some case reports sometimes. Of course, we know case reports aren't the strongest level of evidence, and very often those case reports are usually warnings. They're warnings of what could happen if we misuse a particular product, and very often we include the perspective outside of our current medical westernized culture. In many cultures and communities, the use of herbals and traditional medicine is ingrained in their medical practice. I think of Eastern Asia, Southeast Asia, even Germany, South America, the use of herbals and nutraceuticals is very tightly and deeply intertwined with the way they practice medicine. And there's a little bit actually even more research around it. And I think we need to start being more open-minded about those traditional uses that have been used for thousands of years and do more literature around that so that we can more safely use it in our practices as well. So let's talk a little bit about herbs and understand some of the pharmacognosy, and I'll go through these a little bit quickly. If you're interested in more of this, pop it into the Q&A. We could talk a little bit more about it. But essentially, the active constituents in herbs are what dictate and facilitate its mechanisms. This is, again, part of the pharmacognosy aspect of learning how to make more medicine, right? So we've got compounds like phenolics, your tannins, lignans, quinolones, phenolic glycosides, terpenoids, alkaloids, peptides, polysaccharides, resins, and essential oils. And depending on the formulation, you might have different potencies of different parts. And also, not every plant has all of these constituents. And then some of them, and depending on how they're made and how they're produced, might have stronger aspects in certain constituents and not as strong aspects in others. So that's why you'll see certain trademarked constituents that are used in a lot of formulations that have been shown or proven to be really effective in a particular condition. And then you'll see a different constituent that's a different mixture of those constituents that's used in a different condition. And as a result of that, you're going to have all these various factors that are going to impact that drug-herb interaction. So there's the baseline. Who are you treating? That patient, what's their age, what's their pre-existing conditions, diet, genetics, et cetera. What's their own pharmacokinetic profile? Like, how do they metabolize things, and what aspects in this very multi-step process are they better or weaker in? What are the factors that are going into that material? As I just explained, what particular formulation, where was that herb grown? How was it produced and manufactured? Was it hybridized in a way to produce more of a certain component for a certain medicinal use, et cetera? And then there is the pharmacologic profile. Is it going to interact with that medication in a way that's additive, that's going to increase the activity of that original medication? Is it going to work in a way that's antagonistic, that's going to counter it? Or is it going to be synergistic? Is it going to double down on the beneficial activity of a mechanism? So when we consider the biotransformation, that detoxification pathway, the biotransformation exit strategy for both the medication and the herb, the most common mechanisms have to do with how it alters the pharmacokinetics, how the drug acts in the body. It also can increase the drug's metabolism, which can then result in therapeutic failure in most cases. And it could also decrease the drug's metabolism, leading to a potential decrease, a potential interaction where you have elevations of that mechanism, potentially causing toxicity. And then there would be that classic CYP450 that I talked about earlier, where it's upregulating or downregulating that phase 1 detoxification and largely impacting the way that that drug either gets activated or gets removed in the body. So let's talk about some specific examples of DHI. Number one, licorice. This is a very common interaction. So there's licorice and there's DGL, which is deglycerized licorice. The literature doesn't distinguish the two. Licorice is often used as an adaptogen for adrenal health, where deglycerized or DGL is often used for GI, nausea, upset stomach, gastritis. So you can see there on this table where there's a list of medications and the potential effect where licorice has on that medication. And one of the things I want you to keep in mind when you read through these is that some of these interactions are quite low, like they're quite low risk. So, and then some interactions are quite high risk. And so I will want to think about whether or not that's an relevant interaction, if it's worth it to take the risk to use this particular herb. And then furthermore, is there an alternative herb that I can use, or frankly, an alternative medication that we could use in order to potentially reduce the risk of that interaction? Another example would be St. John's wort. St. John's wort is probably, I see this in my nightmares. I remember back in pharmacy school being told how terrible this herb was. Turns out it actually is a really interesting herb that has a very similar mechanism to SSRIs. It actually has alternative mechanisms as well that make it really effective for depression, sleeplessness, and anxiety. But the problem is it is an inducer of that 3A4 pathway, as well as glycoproteins, and as a result, increases the toxicity of certain medications by up to 80% and reduces plasma concentrations of many medications. This is the long list of medications, and I highlighted bolded antidepressants because there's, in addition to the detoxification profile, it also has the same mechanism of action. So there's a theoretical increased risk of serotonin syndrome with St. John's wort taken with an SSRI. So we want to be really careful. That said, when you look at the level of evidence that we have on these interactions, the majority of them are fair. One is good. And so that just goes back to say we don't have a lot of data really substantiating these interactions. Many of these interactions have been extrapolated from animal models and theoretical models, and we don't have a lot of clinical trials, which is fair. I don't want to see a trial where you give somebody an oral contraceptive and St. John's wort and see what happens. It's probably not very ethical. However, I just want you to keep that in mind. Again, what is the level of evidence? Is there a better alternative that we can switch them to so that we can avoid this whole messy situation altogether? Ginkgo biloba, very commonly used for memory, cognition, has a few key active ingredients, but it's also an inducer of the CYP2C19 pathway. And this pathway is particularly needed for the metabolism of a particular PPI called omeprazole. It's probably the #1 PPI used over the counter and by prescription. And the problem is this has been implied in vivo, but we do not have significant clinical evidence of this interaction being significant. Other potential candidates that use a similar pathway: anticoagulants, antiplatelets, anticonvulsants, antidiabetics. The bolded ones are more significant than the unbolded ones, but I would say, you know, outside of the anti-diabetic medications, there's a significant risk factor. I don't want to take a chance that it's going to inhibit somebody's anticonvulsant or alter the pharmacology of their anticonvulsant and risk a seizure. So I'm not going to take a chance with the ginkgo in those cases. The anti-diabetes drugs, you know, maybe I can monitor their blood sugar levels, but again, are there other better alternatives in those cases? And again, drilling down into the level of evidence, they're fair, if not poor. So again, we don't have a lot of clinical data really establishing how significant they are, but when you look at the severity and the potential risk, look at antiplatelets, the second one down, it's a major interaction with only fair level of evidence. I'm not going to take a chance. I'm going to skip it. And so there are other alternatives that we can use and support. What about ginseng? That example I gave you earlier, this is specifically Panax ginseng. This drug can potentially interact with, this herb can potentially interact with immunosuppressants, hypoglycemic agents, anticoagulants. The risk is largely due to increased blood pressure. And so it's especially problematic with people with hypertension. If you've got somebody who's either the low blood pressure, or normotensive, then it may not be such a big deal. And it seems to also increase GI irritability, particularly in somebody who's also ingesting caffeine regularly. Turmeric, one of my favorite nutrients, herbals to use. I often say, you know, this is probably like a magic herb that's been gifted to us by the gods, but it has its major constituent are the curcuminoids. The mechanism of actions are largely on inflammation, but it also has some specific mechanisms that pertain to some of the detoxification pathways, and as a result can have certain interactions, most notably anticoagulants, anti-diabetic medication, sulfalazine, which is an older medication, you don't see it very often, and then tamoxifen. And the thing I want to emphasize here is that there are some synergistic potentials here. There's actually some studies that show that the use of turmeric with an NSAID or acetaminophen for pain management might actually reduce the need for multiple dosing or increased dose on the medication. So this could potentially be protective for the GI while improving pain management at the same time. And, you know, I get this question a lot. Is it okay to use turmeric if somebody's on an antiplatelet medication? Look, arguably, the data on this is also very sparse. There's only really 2 case reports, a very low level of evidence that there was an increased INR with warfarin. And clinical data is really, really sparse when it comes to its impact on platelet activity with other anticoagulants. Again, would I take the chance and use it in somebody? Maybe not, but when you think about the potential here for researching this, when we know that inflammation and the benefits of turmeric has systemically on inflammation, how they could be potentially protective, particularly in this patient population, I think there's a lot of missed opportunity. And I think it goes back to our own bias. So some clinical just pearls to walk away with and ideas. Can we capitalize on the DHI? I sort of mentioned that with the turmeric, and I alluded to this idea of positive synergy. One example of that would be resveratrol. In this particular clinical trial, it was an RCT trial. They used it with meloxicam in a double-blind RCT. And what's really fascinating about this is the group that received the resveratrol with the meloxicam not only experience improved pain management, but also their inflammatory markers all improved down the line. So there was not only a symptomatic improvement, but there was also an improvement in their laboratory markers, including their CRP, which is a major risk factor for cardiovascular events, which is a major adverse reaction that happens from NSAIDs. Another example, curcuminoids, this time with diclofenac. Again, this is with knee osteoporosis. And in this case, we found that they not only didn't improve their pain management and reached for rescue anti-inflammatory and pain management less, but they also had a significant decrease in GI side effects and needed GI rescue medications less. So not only are we improving outcomes, but again, reducing significant risk factors associated with NSAIDs. And then this one is piperine, which is derived from pepper. Use with chemo. This has actually been used for a long time to reduce the dose needed of certain chemo agents. As a result, reducing the risk of potential let me first say, increasing the bioavailability of the chemo agent and reducing the potential for resistance for that agent as well. So improving outcomes in that way without having to increase the dose. So I want to sort of very briefly touch on this idea of deprescribing. Again, this is not likely in your scope of practice, but it's something that comes up very often. The idea is to think about how somebody could potentially get off of a medication. Very often we use some of the basic principles that are in what we understand about drug-herb interaction, drug-induced nutrient depletions. And one of the first things that we would do is think about putting a foundation of diet and lifestyle to support whatever endpoint that medication is for. And frankly, if you just stop here, you're doing a lot more than most patients are getting in their primary care practices. From there, we can start to assess medication use and whether or not it's impacting their nutrient status. So this is where the DNIs and the drug-induced nutrient depletions can come in and sort of closing the gap on the potential for those adverse reactions as a result. From there, if we're going to add any herbals, if you're going to recommend any nutraceuticals within your scope of practice, you want to review any drug-induced, drug-nutrient interactions or drug-herb interactions to make sure that there's not going to be any negative risk. But also, this is an opportunity to screen for a positive improvement in their risk. And from there, should it be within your scope to then deprescribe, you would then decide whether or not it could be tapered off, or if it is, you can cold jump off of it. And then from there, you would review the plan, make sure the patient's on board with all the steps that they have to go through, and that if you're not the prescriber, that the prescriber is also on board for that. So I'm going to do a very quick case vignette. I know we're a little bit over time here. Hopefully we can wrap this up in the next 10 minutes. Sorry, my apologies. So case is Steve. Steve is a 41-year-old man with a history of dyslipidemia. He's been taking atorvastatin 40 milligrams for 1 year. He has low cardiovascular risk, but his hyperlipidemia has been controlled with a statin at this point. A1C is 5.5, fasting blood sugar is under 100. He's a non-smoker, but he does drink 4 to 6 nights a week. Other symptoms, he doesn't have any GI issues. So from an absorption perspective, he's good. From a detoxification perspective, he's at least moving his bowels daily. He does experience some work-related stress and fatigue and insomnia. His diet is pretty typical. He eats out pretty often when he's not working from home, and he does stop at happy hour or have a beer or drink at the end of the day to relax. He is a regular coffee drinker, and he tends to drink it light and sweet, so pretty good amount of sugar in there. So in this case, he is taking a statin. He wants to come off of it. One of the first things we're going to do is apply foundational dietary lifestyle interventions before we even make any decisions about deprescribing or taking him off the statin. That's going to be the first step. From there, we're going to address any nutritional gaps with statins. That's CoQ10. That's a low-hanging fruit and has a lot of implications systemically on inflammation, etc. We want to initiate nutraceutical support. So in this case, we might consider any other nutrients that might be supportive of his cardiovascular health or his blood sugar balance, liver health, etc., especially with his history of alcohol. And from there, we don't need to taper down his statin, but we do want to determine the risk versus benefits of discontinuing his statin. So what we would do is we would plug it into a calculator, and I'll show you that in just a second. And from there, we might consider putting him on a nutraceutical that would have a similar lipid lowering effect. So something like MedStopper, this is a website where you can essentially put in the information and it tells you the potential risk. And in this case, for him, there is a reduced risk of future disease by keeping him on the statin, according to the literature. So, of course, this is something that he would have to discuss with his prescriber. Some of the DIND that we can, again, low-hanging fruit, CoQ10 is the most significant in the red, are going to be significant, but not as well established in the literature. And then the grays are mentioned in the literature, but not quite significant. So I would focus on the CoQ10 as a starting point, but you might find that, for example, vitamin E, specific tocopherols are useful for cardiovascular health. So it might make sense to just add those on. Somebody mentioned omega-3s in the chat before. So EFAs, again, even though it's not a significant interaction, it might make sense to put him on an omega-3. And a vitamin D probably should go on everybody's list. And then from there, we're going to have a conversation about foundational dietary and lifestyle recommendations. For him, it might be a Mediterranean-style diet, focusing on specific therapeutic foods like extra virgin olive oil, nuts, seeds, including more garlic, which is really helpful for lipid metabolism, encouraging him to eat the rainbow. That's really effective for it as an anti-inflammatory approach, and encouraging him to add more herbs, spices, etc., hydrating more frequently and reducing his overall sugar intake. Then, of course, lifestyle recommendations like increasing his activity, particularly focusing on walking maybe in the evening to balance his blood sugar, as well as to encourage him to do HIIT type activities or muscle building type activities to improve his cardiovascular health in general. Some of the foundations of the Mediterranean diet, probably the reason we might prescribe it is because it has a similar benefit as some medications do. So the magnitude of risk reduction is about 30% using Mediterranean diet, which is similar to the use of statin in certain trials. This is because not only of the balance of the macronutrients and the types of fats and fibers that are in there, but also because it's anti-inflammatory, antioxidant rich in phytonutrients and polyphenols, all of which work synergistically both with the microbiome and with somebody's epigenetics to improve their metabolic health overall. And this was Steve's specific lifestyle modification prescription. If you want to take a pause and read it in more detail, I invite you to do that. And then the next couple of slides, I'll kind of skim through just to give you an idea of how much you could do with nutraceuticals, the various mechanisms of action, and how they can work synergistically for specific endpoints. So for example, bergamot, curcumin, EGCG, et cetera, in that first column have a similar effect as statins in terms of inhibiting that HMG-CoA reductase enzyme that's responsible for reducing cholesterol. But I'll let you go through these in more detail. This was the specific nutraceutical prescription that we used with Steve. Some of these, again, are polyphenols, are going to have this anti-inflammatory effect. Some of these have a direct impact on his cholesterol. And again, some of this may not fit into your specific practice, but I just wanted you to see the potential and consider where it might fit into your practice. So again, we always want to make sure that we're educating on these mechanisms ourselves and understanding their potential, both within within our patient population, as well as where it could potentially harm when it comes to drug interactions. We want to prioritize our patients' education, limit our own bias when we're having this conversation to encourage them to tell us about the herbs and supplements that they're taking. We want to acknowledge the bio-individual variations, environmental factors, weigh the clinical significance of the evidence that we have. And this is where building collaborative teams, working with other prescribers and clinicians, nutrition professionals and pharmacists to establish a good relationship really comes in handy. And I encourage you to also join me in advocating for more research, more studies, so that we can work together to have better resources for our patients collectively. And I want to leave you, the last few slides are some of my favorite resources. These are some of my favorite resources for drug-herb interactions. For DIND, this is a paper that I cited extensively in this particular presentation. And these are two databases. MyTavin is currently free and available. I find it to be pretty well cited, well searched, but Natural Medicines is probably the gold standard when it comes to that, but it is a paid subscription. So in summary, using a holistic approach for medication management helps us to improve our patient outcomes and mitigate risks. Becoming familiar with the opportunities when it comes to DIND and DHI is really prudent for all of us as clinicians, but just always be mindful of your scope and your role within that relationship. It's the clinician, if you're a clinician who's prescribing any type of medication or managing patients on medications or recommending nutraceuticals, it's really important for us to understand both the interactions and the synergistic opportunities, and evaluating the level of evidence and understanding that this is a clinical prudence is required here, and this is more of an art than a science. Do your best to put on the training wheel. So just because you can't manage the medication doesn't mean that there aren't lifestyle pieces that you can start to apply. And remember, collaboration, collaboration, collaboration. Build a team of network of professionals that are like-minded, other prescribers, ocular professionals, nutrition professionals, pharmacists, and other team members that can really help to ensure the safest and most positive outcome for your patients and your community. So thank you so much for your attention, and I appreciate your patience, even though I ran a little bit late this morning.
Lara, Dr. Lara, that was amazing. To say the least. Can you see my screen now? Well, in a nutshell, I don't know what the folks out there are thinking, but I could basically take your lecture and make like 20 of them. There's so much need in our profession to understand this, because eye care is a very proactive profession for nutraceutical prescribing. And I do think that it's going to be an amazing collaboration having you in our society, because more and more optometrists have been prescribing medications within their state licensing, and we have to understand this. And I can go through so many points that you brought up in a general clinic that we would be able to apply starting tomorrow. I do think we need these slides. Your blog is very helpful. That just went up on our website. I did answer a few of the open-ended questions. I know we're over time, but what I really want to emphasize here is someone like myself, and I'm going to give myself an example. There's no HIPAA going on. I'm the president of OWNS. I am a CNS. I have all these nutritional education paths. I need IV infusion. I had lid myokemia for 2 months with magnesium deficiency. Those are just the top 2 recently. So this is happening in your patients, even in proactive patients, that you don't realize. If you don't dig a little bit deeper, you may not actually be able to figure out what's wrong with them. And you really can guide them by referring them to a nutritionist, referring them to a collaborative pharmacist. This is a huge topic. And I think you really, stuck yourself in a major issue here, because we're going to have a lot of requests for you to come back about this. This is a necessary guideline. This is necessary for us to know as healthcare providers. So a lot of amazing information. I can read every slide. I just want word for word. So we're going to get those slides to everyone because I know what everyone's thinking here. We need this information and we need it fast because we are prescribing nutraceuticals all the time. And yeah, I just want to thank you for that. I want to thank everyone for joining us today. As I said, we understand that this is a huge topic of need. And Dr. Lara, you can contact her. Her email's up, hello@larazakaria.com. She's on social media, always giving amazing information. I can't keep up with the content. So without further ado, any last remarks, Dr. Lara?
No, thank you so much for that kind final thoughts, and I really appreciate it. It's genuinely my privilege to be here and to be able to have these conversations. And I'm a big collaborator. I'm a big fan of the idea of us working together, because I don't know about you. We all came into this field, into medicine, so that we can help people. We want to see people thrive in our respective specialties and fields, and we all have our passions. And I've talked to so many ophthalmologists at this point, and you all are so passionate, not only about the eye, but like specific areas and specific opportunities within your communities. And so it's absolutely my privilege to be able to give back to that, and in any way to assist. Please don't hesitate to reach out. I am probably too active on Instagram, so you can always find me there, as well as on LinkedIn for sure. Let's keep this conversation going.
Yeah, and this is a COPE approved webinar. Your certificate will be in your survey. You will receive that within the next 3 to 5 days via email. There will be a survey and a download for your certificate for the credits for today. And I will say, COPE approved this lecture without any questions. So that's just to show you how much they want this type of information within the lecturing world. So thank you so much, everyone. I'm going to end the meeting, and enjoy the weekend, and